Now, when we are choosing for our patient, when they are coming to us, our patients, they concern about how they are to be asymptomatic, and they don't concern about what our discussion and markers and all what we did or all what we are discussing. They concerned how to be relieved from their symptoms. Next, please, because it's not coming next. So ocular surface inflammation as a key factor in many conditions such as the dry eye and allergic conjunctivitis. The timely and appropriate use of anti-inflammatory therapy is crucial for symptom relief and prevention of chronic damage. Second, it's not working for the second. It's not moving.
This one.
Oh.
This one.
Disruption of tear film as a pathophysiologic of the ocular surface inflammation that's mentioned in summary. It's a disruption of the tear film epithelial barrier. So we have instability, and we have a release of the cytokines and recruitment of inflammatory cells with the chronic cycle leading to the ocular surface damage. And all of us, we know this cycle. As a classification for the anti-inflammatory therapy that we have a corticosteroid, prednisolone, fluoromethalone, liptopredinol, and immunomodulator, liftigrast, cyclosporine, and tacrolimus. Corticosteroid, by its action, it inhibits phospholipase A2, so block prostaglandin and leukotriene, so block the prostaglandin and the modulator. So it work on the two line. And it's not only that, it's very fast in action, considering that if we are using liftigrast, we need to wait for 2 weeks for the action to start, and it's block one line, that's the modulator. If we are using cyclosporine, same, we need to wait for 3 months to start, comparing to few hours. So rapid onset, powerful anti-inflammatory action indicated in, as we know, in severe allergy. I consider that the steroid we should start with as a boostering for a short period. That gives the patient the relief, because patient looking for relieving of his symptoms, especially when he is in acute onset of a dry eye, filamentary keratitis, and all the breakup time is 0. We have patients that their breakup time is 0. When we are treating those patients directly with the non-steroidal immunomodulator and adding to it one line artificial tear, 100% the symptoms will not disappear. But we need to have a caution that it raises the intraocular pressure, it creates a cataract, and delay healing. But as I said, it's a boostering, so we need to use it for a short time. And that's the action. As I said, it's block two lines, the prostaglandin and the modulator. And it's very quick action. So if we will go to the immune modulator, we have the liftigrast, cyclosporine, and tacrolimus. And if we'll go to the action of the liftigrast blocking the LFA1, ICAM1, so preventing the T cell activation. So it's block one line. It needs 2 weeks to act in this way. So it will deactivate the T cell. It will delay the recruitment or prevent the recruitment and release of inflammatory mediator therapy, decreasing the inflammatory response in dry eye disease. And really, I trust this material, and I'm using it because it's, as Dr. Shetty said, it's more quicker than the cyclosporine. Comparing to the cyclosporine, where it blocks the cell-mediated immune, and it inhibits the T cell activation and inhibits IL-2 production, and is a little bit more delay than liftigrast. And it's only preventing, not treating, not breaking the immune synapse. So when we are using it in acute patient, the immune synapse will not break, comparing to the breaking action of the liftigrast. Liftigrast is preventing and breaking this immune synapse. Tacrolimus act by reducing the peptidyl proly isomers activity by binding to the immunophilin FKBP12 and creating a new complex. This inhibits both T lymphocyte sign transduction and IL-2 transcription. Actually, I don't have any experience with the tacrolimus. Surface inflammation in dry eye disease. So chronic inflammation damage lacrimal gland and ocular surface. Combined therapy, lubricant that contain hyaluronic acid, lipid, mucin compensation material, carbamide or methylcellulose. Steroid, short course, 1 to 4 weeks. Liftigrast or cyclosporine aim to break the inflammatory cycle and restore tear film stability. So when to use steroid versus non-steroidal. Clinical scenario and preferable. The acute inflammation, for sure, we need to use the steroid. Chronic, mild inflammation, liftigrast or cyclosporine. Post-surgical inflammation, steroid, then 1 week after the surgery, use the liftigrast or cyclosporine, especially for those that they have that we diagnose them as a dry eye and we treat them, but they are still under the treatment and we did the cataract surgery, so we wait for 1 week for the full healing, because liftigrast, it might delay, or the cyclosporine, it might delay the healing process, so we'll wait for 1 week, then we will add the liftigrast or cyclosporine. So understand the underlying inflammatory before selecting therapy. Use steroid for acute control and immunomodulator for maintenance. Balance efficacy with safety. Monitor IOP and ocular surface health. The goal to achieve a sustained, comfortable, and visual activity. Thank you very much.